Hi, my name is Harvey Hawes. I'm a trauma surgeon at Vancouver General Hospital and one of the co-founders of LHS Labs. I'd like to talk to you today about distributed remote medical manufacturing and the problems of austerity in the medical health system. When we talk about an austere environment, medically we're talking about a lack of healthcare facilities, energy, staff, or equipment. There's different levels of austerity, and of course the most extreme is when we get off the planet and separated by incredible distances with minimal staff, incredible costs to get there, and extreme conditions. But there are places closer to home that are almost as extreme, and these are low-resourced areas in high-income countries. A good example is Canada's extreme north. Even though there's shorter travel times, you face different challenges there where you have a large, chronically underserved population. Then there's the economically remote. Economic barriers to healthcare are immense, best probably seen in sub-Saharan Africa and other low middle income countries, and also in conflict zones. And while we all care about our patients, it's the available medical equipment that dictates what, where, and how long we can provide medical care. And often it's one of the reasons why healthcare staff leave. If they're not able to provide care, there's a sense of frustration and they're not able to ethically stay in those situations. There's also considerations around the mission itself. It's a short-term mission, and usually you're dealing with a small number of fit, healthy people. However, in longer-term or permanent missions, you have a larger underserved population, usually a community that's around you with chronic illnesses, and those are very different settings. We talk about the challenges. As we mentioned, there's the geography, environment, duration. There's the diversity of equipment needed and the patient population that you're serving, which is also quite diverse. There's transient or non-existent supply and resupply chains. There's transport issues, and then maintenance and repair that always happens. I'd like to also touch on waste. Most of the medical devices today are single-use disposable plastic and wrapped in layers of packaging. Most of that packaging, of course, is useless to the mission, and packaging and waste become the enemy of remote healthcare. Waste robs supply chain of transport volume and mass, with significant carbon implications and environmental implications, especially around disposal. So how can we solve this? Well, austerity itself could largely be solved by reimagining medical device design inputs, manufacturing, supply chain, procurement, and the business models. The solution that's needed is an adaptive, deployed, on-demand, low-cost, low-waste, circular manufacturing and resupply system. This will support the dynamic needs of remote missions. This will be a distributed network of remote medical manufacturing plants like the one we've conceptualized here, and we're working on a prototype. And these can be adaptable for use in space or any hospital on Earth, whether it be remote or even urban. Again, in this example, this is a left to right workflow where raw materials come in from the left side, they're manufactured into devices in the middle, and then they're ready for use out the right side. We now have rugged medical grade manufacturing devices like 3D printers. And this is an example of 3D printers that can be used after they've been dropped off a truck, and they can even print while being transported. This has been a key element for remote medical manufacturing. But what we're really talking about here is automated manufacturing. And the software is most of the solution. And this will be ISO 13485 compliant because each of these units will be manufacturers of record. But with the right software development, we can allow for a click and print system. And in this concept here, a clinician can actually initiate the manufacturing process, select a part from a secure cloud catalog, and then use the hardware to print it. There will be an automated QA system to ensure that the device actually is printed as it's supposed to be, and the clinician can then use the device usually in around a day. So why haven't we done this before? Well, it's taken some time to get the manufacturing technique and materials that we needed, but those are changing rapidly. There's been a lot of regulatory ambiguity, certainly with Health Canada and FDA, and the business models have been not adapted to the strategy. It's very hard to convince large medical device manufacturers to service this market. And if you're to start something on your own, the investor timelines are very different than the amount of R&D needed for these kind of endeavors. But mostly it's a lack of shared vision, and that's where conferences like this can really help. So there's some innovation needed. There's easy innovation, and you see this now, people putting printers in shipping containers, but that's really not going to get you that far. What's a little bit harder to do is make it easy to use and create a useful catalog of approved medical devices with approved materials as well. What's much harder is when you look at going from class 1 devices up to higher class devices such as mechanical ventilators or IV pumps. They can be done, but it takes a significant amount of R&D. And what's also difficult is staying abreast of the regulatory requirements, and these are changing quite rapidly. What's needed in terms of innovation as well, as I said, are these automated quality systems. And there's now technologies like digital twinning that can be applied to 3D printers to ensure that print quality is where it needs to be. And as well, we would like to integrate these systems into EHRs and inventory management systems to help with providing medical care and costing medical care. We think there's a timeline towards this. We're working on an 8-month timeline towards a prototype that would be a proof of concept, very much like the one you saw in the pictures before. We think probably within 3 years we'll be able to deploy these to Canadian North to test it out in that environment. We think at that point we'd already be able to provide value, and that would allow them to provide more care than they're currently applying, and the feedback would be very valuable. And that would also allow us in the course of about 5 years to consider deployment for space, but obviously the challenges there are much greater. But if we get this right, this would be a disruptive innovation. It would disrupt the traditional medical device business models and hopefully the inequalities, inequities, and austerity that happen because of those business models. And it would allow us anywhere in the solar system to develop and manufacture quality medical devices for patient care. Thank you.